Or in some cases, you should introduce, for example, two, in this case, antennas, microwave antennas, into this big lesion. But if you space your antennas too largely, this is useless because the middle portion will be not treated. If you introduce your antennas too close to each other, you have again not enough treatment because the external portion will not be treated. We know that 2 centimeters is the ideal spacing between the two antennas to get the maximum result. What can you do? You introduce the first antenna and you mark in green where this has been placed. Then you introduce the second one, and you, in live modality, you measure the distance between the center of this oval shape here and the center of the previous oval. If this distance is approximately 2 centimeters, it means that you can start the treatment and start treating the tumor. So, why fusion imaging? This is a list of possible indications. Lesions best identified with CT, MRI, or PET. Best, it means better than with ultrasound, for sure. A lesion not seen at all with ultrasound. Or lesions only seen in arterial phase. You cannot perform a treatment on a lesion which is visible only in arterial phase, which lasts 15, 20 seconds and then disappears. Under CT, it's impossible. Under sonography, again, very difficult. Using the system, you can do. And you will see also other possible indications. Lesions hidden during treatment because of a gas. Identification of the safest pathway to the lesion. Localizing specific part of the tumor for biopsy. And I will show you briefly a few examples. Very difficult to treat lesions like this in the dome of the liver, adjacent to the vena cava, entirely surrounded by the lung. Using the system, you see the perfect treatment without any complication. Again, very difficult lesion, excellent treatment. Extremely difficult lesion, entirely surrounded by the lung, excellent treatment, again, no complications. A patient with colorectal net, a young patient, who had received surgery again, and then he started to be ablated. Now we have ablated this young woman 9 times for new metastasis coming out. Chemotherapy does not work. Surgery cannot be repeated anytime. She comes back with this new lesion here in the middle of many other lesions treated. Very difficult to recognize this new lesion in the middle of so many treatments. So we use the fusion system. We recognize which is the viable tumor, and we stick the electrode exactly into that one. And the next day, 24 hours, you see that you have treated with enough large volume the new metastasis. Lesions not seen in ultrasound. I showed 2 examples just now. You remember the examples of the 2 small metastases. So I skip this case here, which is another case of difficult lesion. Lesions seen only in arterial phase. This is an example discussed in Tampa recently with my friend Brad Wood from Bethesda. The other big center in the world with great interest in this kind of modality is just Bethesda. And this is a typical, he says, typical American patient. It means 1 meter and 60 centimeters tall and 100 kilograms weighing with cirrhosis. Where is the lesion? I don't know. Difficult to find the liver also. Where is the lesion? In non-contrast enhanced CT, invisible. Only with contrast enhanced CT, you find the lesion. Sorry, the lesions, 1 and 2. So how can you get those lesions? You can treat your lesions if you can only see them in the 20 seconds of the arterial phase under CT. Impossible. You fuse ultrasound and CT, and you get the result. And this is the result, 1 and the second, correctly targeted without any local complication. Another case in our department, lesion here, hepatocellular carcinoma, not very large, in a very difficult position, in a very big person, very big patient. Very difficult to find, impossible for sonography. Treatment, control with enhanced sonography just at the end of the treatment, control 24 hours later with CT, perfect targeting. Just a few numbers. In this period, 7 years, more than 300 patients treated using this system, mostly liver. Lesions treated are 884. You see here the size range. And you see that 340 were smaller than 15 millimeters. Why am I underlining this number here? Because this is the most important meaning to perform ablations in the year 2000 and on. You should not treat lesions 7 centimeters, 8 centimeters. The good results are achieved in this range of size. If you ablate precisely this kind of lesions, whatever they are, metastasis from any kind of tumor or hepatocellular carcinomas, you get a good result. When you treat larger lesions and larger, results are not so good. You see here that the average registration error is between 2.2 and 8.1 millimeters. The mean is 5 millimeters. And you see also that lesions totally missed or unablated in a total of 884 are only 7. And I think that this number explains the whole importance of this kind of system. Lesions undetectable with sonography, correct targeting in 142 out of 153. So in almost 93% of the cases, totally blind, not visible with sonography. Again, important numbers. But things change. Last year, when I was here, I showed you this, I showed the people here in the room, this image of my football team, AC Milan. And I said that there are strict connections between Italy and Brazil, because all these were playing in my team, Brazilians. Now Kaká is no longer playing in our team. He's playing in Real Madrid. And when things change generally in the world, sometimes improve, sometimes worsen. In technology, unfortunately, when things change, usually they improve. So we have some improvements. And this is the future. I will show you just a few minutes, really, the last few minutes of my presentation regarding the future. But this, in my opinion, this is the most important, most crucial part of that. Probably this year in Chicago, the RSNA, in the end of November, most of what I show you now will be clearly visible